Thank you, sir. There are two corrections. I am not surgical oncologist. I am urologist. Switched over to uro-oncology. And I'll be speaking
Surgical uro-oncologist.
In addition, I do gynae-oncology also for last 15 years. And I'll be speaking actually what we have done in Rajiv Gandhi. Because Rajiv Gandhi Cancer Institute is the only exclusive cancer center in the country which has Da Vinci robot. Tata doesn't have it, so I can't tell their experiences. But having said that, doesn't mean that other centers where the robot is, they are not doing oncology. They are doing oncology, but they're very recent. So I'll be talking about my experiences because we have used this robot in gynae, uro, thoracic, GIT, and we are planning to use it in head and neck cancer also. You all know that last decade had been very exciting as far as technological revolution is concerned. Nanotechnology, cloning, genomic mapping, minimally invasive surgery, which actually evolved from laparoscopy to robot and now single port also, genetically altered food and teletherapeutic, and the list is endless. In 2000, I worked in US in a molecular oncology lab, and they were of the opinion that the research pace which is nowadays is very high, which was 20 years back. The reason was that all the process they were minimized to the computerized rather, and the time which the one experiment used to take around 4 days, that experiment will finish in 4 hours. That happens to PCR actually, polymerase chain reaction. This used to take many hours and it was minimized to only 1 hour 15 minutes. This is the pace, this is how the research is evolving, and the pace is very high nowadays. What you feel this will happen after 10 years, this may happen even earlier. We all know that we have evolved in the surgery especially. We have evolved from the simple surgery to complex surgery, and with that comes to in the cancer especially comes to the clearance of the cancer. The main aim of cancer surgery is first that we can do the good outcome as far as the cancer control is concerned. Without compromising cancer control, can we reduce the pain? Can we decrease the stay in the hospital of the patient? Can we reduce the blood loss, or can we reduce the narcotic use? These are the main problem in the cancer when you operate these patients. And if in practice, if you sit, especially in the center where I work, most of the patient, they will not bother about incision or maybe they don't want early recovery. They want cancer should be controlled very effectively as it should be for the open surgery. And having said that, this is a quote from William Osler: disease that harm requires treatments that are harmless. It is better you give the minimal pain, minimal incision, and so that patient can go home. Laparoscopy had been in the field for a long time, and the problem with the laparoscopy is that it is not users friendly. Last 15 to 20 years, we have seen that laparoscopy has not gone very effectively into the surgical field except in the lap chole or maybe the nephrectomies or other simple hysterectomy. When it comes to the cancer, everybody keeps his opinion are reserved. I myself do only laparoscopic radical nephrectomy. I don't do any other surgery with a laparoscopy in our center. It has problem with the dexterity. If the patient is operating, they definitely have a lot of problem. Tactile challenges are there. There's a slow movement. There is disorientation because you have 2D vision. There are technological advances where 3D visions are there. Small size instruments inside the body, the restricted degree of freedom. That's the biggest problem. The fulcrum is at the abdominal wall, not inside as you see in the robot. Resting tremors are there and they are amplified because you move here something, it moves more inside the body. So to overcome that, things came which is actually a fulfillment, not transition, the robot. In this, the finger, hand and wrist, they all are inside the body. This is endo wrist is inside the body. I'll be showing the video. These videos we have prepared in our center. And you are more precise when you operate, and the dexterity is really maintained. There is no problem is as effective as you do in open surgery. There are some pitfalls which can be rather overcome with other advantages. Laparoscopy, I told you the disadvantages. What are the problem? Definition of a robot, if you go, is the machine that resembles a human and does mechanical routine task on command. It's not that robot will operate on its own. That thing has not come yet. Any mechanical device that operates automatically within the human like a skill under command of surgeon. Robot is not a machine, it is an information system with the arms. There are two types of robot. Passive, this actually has evolved, robot has evolved. The recent robot, the SIHD which we are using, it has gone through many modifications. It's not right that that company was making. This was made all over the world, even in England. First robotic TURP was done in England. It's a passive retractor symptom. You can put a retractor and give it to a robotic arm. It will just retract, it will not do anything. Position of the tool and then hold like camera in the laparoscopy. Many people use that ESOP type arm which actually just stays there and it doesn't move anywhere. If you give it to your assistant, he will be moving the arm. Active robot would actively move the tool upon the surgeon's command, as the present Da Vinci is. Da Vinci, which I am talking about, is the present most popular robot. Actually has replaced any other business in the world, like computer, any growth in the business in the world, the Da Vinci has replaced. The growth which has occurred in this field is phenomenal. This has three parts: robotic cart, console, and endoscopic stack. The high quality magnified surgeon controlled 3D image is actually there on which the surgeon operates. Those things are not visible with the naked eye. These are the earlier robot, the Minerva neurosurgery robot. I was talking about TURP robot, Probot. This was done in England, and Robotic hip replacement in 1995. They are no more popular now. As far as history goes, the Defense Advanced Research Projects Agency, DRPA, for military research for battlefield surgery, actually remote battlefield, this was the main idea, to make a robot that a skilled surgeon sits somewhere and he operates somewhere in the guidance of another surgeon, or maybe unskilled nursing staff or trained nursing staff, he can operate somewhere else. And this was done like cholecystectomy was performed remotely via telesurgery 300 miles away. This was already done. Intuitive Surgicals, this is the only company right now, but hopefully new company will come. Created in 1999 after acquiring the patent rights from military. They borrowed this technology, they made patented, and in 99 this was made, and in 99 late or 2000 it was FDA approved. First robotic radical prostatectomy was performed in 2001 by a Indian surgeon, that is Mani Menon. This is the present robot which we have in our center. This is how you see. This is the console. Surgeon operates here. Surgeons will sit here. The robot is here, and there is an endovision card. Assistant will see here, or you can have another monitor also. You can add as many as monitor you want. In the beginning, there were 3 mechanical arms, 1 for camera, 2 for instrument, but now we have 4. It's a 2 meter high and 1 meter wide robot. It's actually big machine. You require a bigger theater, and the weight is 544 kg. This is how this is on the patient. This is the wrist-like movement. That's what I was talking about. The wrist here, this is the human wrist, and this is the robot wrist. This is the endo wrist. They move inside the body like this. You can move into 570, not 360, 570 degree. It moves like this, and it can come like this. Then you go to 6 degree of movement, and then it moves at the fulcrum also. So they have 7 degree of movement by the instrument itself. But inside it is 6 degree at the tip. Surgical console has binocular vision, in situ vision with instrument controller, system setup controls like diathermy pedal, or when you are controlling the other arms. This is how the surgeon can sit there. There is actually different robot, hopefully will be there in future in the market. Now I'll be showing what cancer surgery can be done, or being done with the robot in the world. I am just starting with the cardiothoracic, which is not a cancer surgery, but the idea is that that robot actually came for cardiac CABG, because this was the maximum number of the CABG used to be done. The manufacturer, they thought they will put this in the hands of cardiac surgeon. However, cardiac surgeon could not make it successful, and luckily they landed up with the prostate. So they always say that we, though aimed at the heart, but we shot prostate. And when the prostatectomy was done with this machine, the radical prostatectomy was the commonest operation. It is still right now also. These are the procedures which one can do with the robot: Whipple's operation, liver resection, liver harvest for transplantation, esophagectomy, fundoplication, and bariatric surgery. In gynecology, this is fastest growing field. Robotic myomectomy, radical hysterectomy, we have done around 40 in last 1 year. Surgery for the pelvic prolapse, we don't do benign surgery in our center. In neuroarm, you can do neurosurgery. And then radical prostatectomy is the largest performed robotic surgery in the entire world, especially in America and West Europe. And we also have done around 25 radical cystectomy, nephrectomy, partial nephrectomy, adrenalectomy, and the benign surgery you can do reconstructive surgery easily because you can do suturing very easy with the robot. As far as our center or India is concerned, first robot in India came in AIMS in 2008. At the same time, it came in actually in Fortis also. But AIMS robot in urology department, it has done a lot of surgery. In the cardiac surgery, it didn't do much till recently. First robotic cancer system in cancer center was Rajiv Gandhi. It has not come, probably Tata is now planning to take. Now Vatakati Institute is supporting many programs in the India, especially in Delhi also. They are bringing 2 more. Right now Delhi has 6. Mumbai, Chennai also robot have come. These are the surgery which we have done: pelvic lymphadenectomy, partial lymphadenectomy, nephrectomy, veil is video endoscopic inguinal lymphadenectomy. We do it. A lot of patient comes to us, and the incision actually is at just above the knee. There are 3-4 ports, 3 incision, and you operate just at the inguinal region. There is no flap necrosis, there is no wound morbidity. Radical hysterectomy, radical cystectomy, and prostatectomy. The other surgery which we have done is lung lobectomy, is done by our thoracic surgeon. Adrenalectomy, appendicectomy. We don't do appendicectomy, I don't know how it's come. Esophagectomy has been done, and we have done 1 APR also. Now, I'll not show these videos, I'll be showing the videos if the time permits. I'll just finish this PowerPoint presentation because the video are separately kept. They will not run in this. So where the next innovation in robot is advanced instrumentation. Energy will change from diathermy to laser, articulated stapling, and the vision will improve, and there is no integrated ultrasound, but the ultrasound is used when you use robotic surgery especially for partial nephrectomies. In near future, there will be single port surgery which are on horizon, and they are highly integrated, and networking, telementoring one can do very easily with them, and the simulation is already there. In midterm, maybe 2 to 4 years, there will be image guidance, haptic touch sensation will be there, notes, natural orifice surgery will be coming, and the focal therapy for the early cancer. And maybe after 8 plus years, there may be automation and procedure specific robots will be developed. Like if you see today is monopolar, bipolar, and RF radio frequency and harmonic scalpel. In tomorrow it will be laser, articulated stapling, plasma, and powered instruments. The only disadvantage right now in robot, which hopefully will go in future, is expense. It is very expensive. $1.4 million is cost, and they have 120,000 US dollar annual maintenance contract also. And disposable instrument which are used per patient is almost $2,000. Hospital reimbursement is same for anything. A steep learning curve, though it is not there in our cases. Increase staff training and competence, increase OR setup and turnover time. Future of surgery is not about the blood and guts, but the future of surgery about bits and bytes. I'll show you some video if Dr. Julka permits me. Do you have time? I have many videos, but I can show you 1 or 2 videos. 3 minutes, 4 minutes. 1? Okay. So I'll show you the RRP. This is the robotic radical prostatectomy, and this is done in our center. This is 4 arm. One is arm for the camera, and these are 3 robotic instruments which are there inside the pelvis. We always do lymphadenectomy before proceeding for radical prostatectomy. This is the external iliac vein. The paravesical space, and this is the vas. This is paravesical space, this is the vas. This is obturator nerve here. Innovation in radical prostatectomy, suturing are already there, and these sutures are available in India also. They are V-lock suture, which have, you don't have to make a knotting at all, which you do only not less anastomosis, not less securing of the dorsovenous plexus. This is the incision at the endopelvic fascia. That's the levator ani. This is when you, this actually prostate is removed by retrograde, antegrade method. While when you do open surgery, it is retrograde. The bladder is opened at the vesicle, prostatovesical junction. You can see the bladder here. You can see the catheter here. Taking DVC is very easy when you do robotic surgery, though this is a big pain when you do open surgery. Over the years, we can do it very easily in open surgery also. But this sutures now are, there is no knot is involved. You just take, they are beaded suture, you just take them and pull it, it will secure. This knotting is not necessary nowadays with the new sutures. If you permit, I can show radical hysterectomy. Okay. Thus the prostate is out. The anastomosis is the one thing which is very easily done with the robot, and you can take around 12 to 14 sutures at the urethra and the bladder, which secures anastomosis nicely, and that is why bladder neck contracture are not there. So with that, with the permission of chairman, I'll end my presentation, though I was very interested in showing the video for hysterectomy. Thank you, sir.